We are on a mission to save and revitalize independent pharmacy. On the Catalyst podcast, we dive into current events that are shaping how pharmacists approach their patients and their businesses. Fuel your passion for pharmacy, one conversation at a time.
3, 2, 1, 0. Ignition.
Welcome to the Catalyst Pharmacy Podcast. I'm your host, Jeff Key, president of PioneerRx, and today I'm here with Mark and Josh.
Hi, I'm Mark Bivins, Vice President of Sales for PioneerRx.
Hi, I'm Josh Howland, Vice President of Clinical Strategy.
Today we are here with Stephanie McGrath, Executive Director of Network Operations for the Pennsylvania Pharmacists Care Network. Stephanie, I don't know, we've met. Jeff Key.
I don't believe so.
I think I'm the only one that's met you live. So.
Oh, well, and this is Mark Bivins. Mark Bivins handles his VP of Sales at Pioneer. I'm the president, was brought in to build a new pharmacy system about 15 years ago.
Great. Nice to meet you. Thank you for all of your work and efforts in that. We've seen a lot of great work coming out of our pharmacies that are Pioneer customers. So
cool.
We've seen the good product of that. Who do
you work for?
That's a good question. So I'm employed through the University of Pittsburgh School of Pharmacy.
Okay, gotcha.
But the PPCN, the Pennsylvania Pharmacists Care Network, pays my salary. I'm a contracted employee through the University of Pittsburgh School of Pharmacy, which is nice because sitting in the School of Pharmacy, I have access to resources, colleagues at Pitt that do data analysis. I work closely with our students, research fellows, and residents on a number of different patient care initiatives. So I have access to all of these great minds and people to bounce ideas off of and work on projects with and things like that. But I am solely funded through the network, the Pennsylvania Pharmacists Care Network.
So in the Pharmacists Care Network, that is the CPCN network?
That is the CPCN network of Pennsylvania, yes.
All right, and so how do they get money?
We have participation fees, so monthly enrollment fees the pharmacies pay. A percentage goes to CPCN USA. We keep some at PPCN. We've also built some program administrative fees into payer contracts as well.
Nice.
And we partnered with our Department of Health, and some of my salary comes from a CDC grant as well.
Very cool.
To work on practice transformation.
I know I've said in meetings where people like Trip Logan and it's like, we need staff people. So I'm always curious that, Pennsylvania seems kind of ahead of that and what they're doing and think about, hey, we got to have somebody who gets up every morning and thinks about this.
Was PPCN, it predates CPESN, correct? Or was it formed, I guess speak to that.
Sure. So it goes back at least 10 years, really, in development. So after I graduated pharmacy school, my first resident, her research project was to take a look at, this was more than 10 years ago now, where pharmacists were across the state providing patient care. What type of setting? Are they in the community, in an institution? Where are they physically? So she gathered and created like a map. So that was the first step in creating a network of pharmacists that were providing any type of clinical care. And then through that, the State Pharmacy Association, the Pennsylvania Pharmacists Association, worked with all 7 schools of pharmacy to create a training program that served as a credentialing entity for pharmacists providing this level of care. So started again to formalize the network. So it really started as a network of pharmacists, now has evolved to a network of pharmacies. So that's why we have Pennsylvania, a different name. We look a little bit different, but we have this really developed infrastructure because it's evolved over the course of like 13 years.
Is it, something I found, I took about a 4-year hiatus and taught college because in my part of the country, it was something that was needed. But I constantly got, this isn't a business. Why are you trying to run this like a business? Students aren't our customers. But in pharmacy, it seems really, a lot of the success going on right now is because academia is involved. And really pharmacy schools seem to have this view of not just research, right? That there actually is this push into the community. Is that a healthcare thing? Is that also like doctors and nurses? Do you see that the same thing in those schools where they're really working through the people?
I think to a degree that's a specific number of pharmacy schools, right? Like Arkansas has done a great job. Pitt's done an amazing job of that as well. Ole Miss has done that. And I think that revolves a little bit around having people like Stephanie available to do it. And then some of the schools like UT Austin, amazing pharmacy school, doesn't really do anything in the community.
Well, how do you, so if we've seen huge success in areas where the colleges were involved, how do we help more pharmacy colleges get involved in their local states? Is that something they talk about? There's a show that has a lot of the colleges in there.
Probably ASHP mid-year would be the biggest one.
Yeah. Do you see move there? Do y'all see you having classes and CEs talking about how to do that? And
Oh, totally. So the ACT Pharmacy Collaborative, which I think you've discussed on previous podcasts, and are familiar with. Yeah, Jordan's very involved with ACT. So I sit on the ACT task force as well. Melissa McGivney and the team at the University of Pittsburgh were some of the founding members of the ACT Collaborative, and now has almost 90, I think, schools of pharmacy involved across the country. And that's helped to support and give recognition to community pharmacy faculty across the country. And that is the deans of those schools have to actually sign off that their faculty are participating in this initiative. So it just gives more recognition for the faculty that this work is important. This work is, should be discussed at our level, should be discussed nationally. And I think it feeds, some ideas and resources to, bidirectionally from the national group to the local, at the local level and so forth. It's made a lot of really great connections, and that's part of the work is amplifying the work that's being done in the community and strengthening those community partnerships. Majority of students still, you can do so much with a pharmacy degree, but as evidenced by the group of us sitting here, but the majority of students still graduate and work in the community. And if schools of pharmacy aren't supporting students in that and their education development in that, they're doing their students a disservice. So I think that's where the University of Pittsburgh, one of the first reasons they really and also recognized the value of supporting the community. And literally, it's not just a pharmacy, it is literally the people that live and work and go to church in that community. It's much bigger than that. Yeah. And they've really embraced that model. When I graduated school in 2007, I distinctly remember Melissa McGivney in our classes saying, like, you need to be paid for your services. I'm teaching you how to be a clinician, but you have to understand how to get paid for that. And that was a large part of my residency training and appreciation as well. So that is really ingrained in students.
Yeah, can you imagine what the world would be like if every college teacher had to work a day a week in their field?
Right.
How the class would be different. Everything. It's just crazy. I remember I was visiting a pharmacy in Georgia based on I try to hit some pieces around the country and ran into a teacher who I knew there. She was working in the back office. It was just a big surprise. But that feeling. Yeah, Aaron, who used to work at Miss Pharmacy.
Okay. Yeah, well, it's also like we've interviewed more and more people that have some connection or relationship now, more with some type of even if it's they're teaching a class and they teach a class every year, whether it's one particular. I feel like there's more and more community involvement that we're even hearing about with community pharmacy being more involved with schools of pharmacies in general.
Yeah, well, if you look at healthcare education historically, when you're a clinical professor, you're still working, right? Mm-hmm. It just historically, when you're a clinical professor in pharmacy school, you're probably working in an ambulatory care clinic or a hospital.
Right.
So now we're starting to see more clinical professors work in community settings, and I think that's awesome.
And helping figure out a revenue model to make the shift the care model, right? That's kind of what you're helping do with CPSN as well.
Totally. And bringing in best practices, guidelines, clinical practice tools as well. I think that's where, I really lean heavily on my team. In fact, now we're trying to figure out how to build a model for home visits. So pharmacists providing home visits, and I need help. Where are the CPT codes that align with that? And, so I'm relying on a resident to help me build that program.
Is that the pharmacist making a home visit? Or is
That
that
the pharmacist. Yeah. So we've had a lot of requests, and I'm talking to my, colleagues nationally about this as well. They're getting the same requests that, patients still, don't have access to vaccines because they can't leave their house. They have mental or physical disabilities or, whatever it may be. And so the pharmacies have been requested to go to the patient's home to provide that immunization. And while they'll do that out of the goodness of their heart, they can't sustain that. They can't do it,
a payment model
in a widespread way. Yeah. So, so we're working with some health plan partners to try to figure out what that looks like, how you would bill for that. But the biggest challenge is just, it's not the buy-in. Like, our health plan colleague partners are so supportive of the work that our community pharmacists are doing, but it's the logistics of, like, what does this look like? How do I actually pay you? How do I get credit for paying you for this service? So that's been really interesting to see, and trying to get, these groups of individuals together who have expertise in provider credentialing and contracting, medical billing, to figure that out.
Is that something billed probably on the med side?
No, they don't want it on them. It depends. So and in fact, pharmacies, I think traditionally would want it built on the med side. So let me just use my dispensing system to do that. But if the dispensing system doesn't have X12 capability, then the health plans may or may not see it. So they rely on the PBM to share it with them. And I think, we collectively as a profession want to get away from relying on a PBM to bill for services. So I'm excited about, one of the things I wanted to ask your team about actually is, is it in the pipeline, integrating into Pioneer, medical billing, X12 billing into the dispensing system, or can it be? Am I allowed to make this request during this? I heard I could talk about anything.
No. We've certainly been very interested in medical billing for years. Probably at least 4 or 5 years.
We've been kicking the tires since I got here.
I had a couple of things. I think there was it Envoy? Who was it? Experian. Yeah, we talked to probably 5 years ago, and they made an offer to us, which was actually pretty reasonable. But there was nobody doing it, So
chicken for the egg kind of thing.
Yeah, and it was kind of like $50 per group of people you accredited with. So if you were a doctor's office, you accredited with everybody at one time. It's different, but pharmacists would have been nickel and diming all the way.
Yeah, it's just such a different model, right? You're paying a different fee to everybody for every pharmacist,
right?
At least back then, for sure. I don't know if it's
right.
changed.
And even then, there
now.
was still a lot of ambiguity, and there still is, right, about the CPT code's fine. That's published, it's available. But how you bill a medical claim versus a pharmacy claim is very different. And there's just not a lot of expertise to be like, hey, the pharmacy claim translates to this, and the modifier codes and all the other stuff that go along with it. And it's easier to figure out when you have people doing it. But when there's like 4 people doing one-offs across the country, it's super hard. So hopefully you guys get some traction, and we can help work with you guys and figure that out.
Yeah, so we'd love to. One of the things we'd love to see is a thing that translates a care plan into an X12.
Yeah.
That there's a piece of an X12. Now we don't want the care plan to be a billing instrument. It wasn't designed to do that. We want a care plan to be sent at multiple events. But one event could be a billing event. And if you had somebody out there who would be like a clearinghouse and transfer that, which is similar to the not the PBM model. I mean, the big model today is that you translate a regular D.0 claim into an X12 document. Companies do that.
Yep. Well, even if you publish a straight up X12, you still have to have a clearinghouse.
Right.
That's what Experian and all those other guys really do.
Good question.
No, good question.
So it's in the pipeline. That's what I heard.
That's what she's
like.
Well, it's something
we're
very interested in and work with a couple.
Right.
I mean, there are a couple of people we work with, different models of that is, whether that be Allwin or FDS or Omnisys, that will take a D.0 claim, give you a way to add some additional data to it. We've been pushing one of them to take a D.0 claim and combine it with an e-care plan and put the data together to make an X12.
I think that's really the future of community pharmacy. I think that's really, in order to improve efficiencies and to be getting pharmacists doing this all the time. I know your team has worked, really hard to help pharmacists improve efficiencies in submitting care plans, but it's the billing for services now that like where we're struggling. Now I've got to log into this other system to submit a medical claim. Like it's clunky, or one of the health plans wants us to submit HCPA forms. Like, really?
Yeah.
Yes. Yeah. And mail them in. So but there's just not enough volume. They're willing to work with us on building an online platform for that. But again, it's going outside of, their workflow to do that.
Sure.
And while physician practices have staff, have a team, have a medical biller, on staff, most pharmacies don't have that. Maybe that's the future too, that all pharmacies will need to have something like that. I hope not. I hope that the technology can support them.
We've played with a model where, you had a company. There are doctors' offices and things that they don't have a medical biller on staff. They outsource that medical billing to to another company who handles that for them, tracks it down, does those kind of things. I think you're probably a long way off from being able to afford a medical biller. And that's that chicken and egg thing. I don't have quite enough to pay for what I need, and somebody's got to invest somewhere, and independent pharmacy doesn't have a lot of money to invest. You almost need to get some kind of big grant or something like that to, build some kind of national clearinghouse or some kind of method. You also wonder if there's going to be some vision of a third method. The downside of medical billing today is it's credentialed on a per provider basis, which is weird in pharmacy.
Yeah.
Pharmacy is usually credentialed on a pharmacy basis as you switch out people.
Right.
And I've seen some models in CPSN where they just say they're doing a third way, which may be, hey, we're billing based on getting a care plan or something like that, because nobody's systems is supporting it.
Right. Yeah, that's what we're struggling with too.
Right. And there's a happy medium, right? The cool thing about pharmacy claims is they're adjudicated in real time. I did this, I get this amount of money, barring DIR fees.
Yeah,
things.
barring it.
But in theory, right, I send something out, I know what I'm getting paid. But with health claims, that's not true at all, right? You've got a sometimes multi-week delay. You have to figure that at some point when these things start to merge, you're like, well, maybe we can take the best of both worlds and do something to say, if you've got all of the clinical documentation in place, I'm going to tell you exactly what you're going to get paid. Right? And the e-care plan could be a mechanism to be able to do that.
Totally. I hope that's the future. I completely agree. And I think our pharmacies would also.
Yeah, it's super interesting and super, we're definitely in a period of change and where some of those decisions are being made. And
sped things up for sure. Stephanie, do you think that could be a sustained need? Because it sounds like payers are willing to pay for somebody who can't get out of their house for someone to come there and do vaccinations and probably something else too. Do you think that's something
a health risk assessment? Yeah. Fall risk assessment. Yeah. PHQ-9. Totally.
Okay.
There's definitely appetite for that. Again, I think it's now that we have buy-in and we have these relationships with health plans and where we've demonstrated value, it's the logistics of setting it up that are the biggest roadblocks.
Yeah, trying to use current infrastructure to do it.
Well, and just expensive. I mean, it's way, way too expensive to send a doctor out. Pharmacists kind of in the middle.
Yeah, and even then.
A nurse may or may not be less expensive. Could you telehealth it some kind of? Could you
maybe put a healthcare worker
connect
in there?
the delivery driver with an iPad that connects to the pharmacist, and kind of it's a facilitated visit. Where the driver can go around and show you can do a fall assessment, you can make sure you got guardrails and things like that. And where it's a pharmacist is there, but it's not. Didn't have to travel there.
Sure.
Right. Well, you even saw through COVID allowing for technicians to be able to immunize, which is shocking that it took this long to do in the first place. But, there's no reason why you couldn't do a quick televisit at the pharmacy and have the delivery driver as a technician provide a vaccine or do some other type of screening under supervision. It makes total sense.
What states are techs?
Because of with the Coronavirus Relief Act, they allowed technicians to immunize for COVID vaccines. I don't know if all states were required to do that, but there were a lot of states that released techs to be able to do that.
Yeah, because I know that the guys I was talking to, one of the stores I visited in Florida, he had actually hired nurses.
Yeah.
With the 2-year nurse to help them with vaccines and some of the clinics and stuff they were doing. So Florida must not have been one that allowed the tax.
Florida is in general not terribly innovative with stuff, kind of like Texas.
Yeah, I don't know. We may deduct that. Sorry, our Florida friends. I guess we picked on Texas too, right?
Yeah, I mean,
Texas. We're in Texas.
Texas has never been like, hey, we're going to be cutting edge in pharmacy, or at least in pharmacy regulations, right?
Yeah. They're getting there now.
Yeah, I don't know. They were one of the early ones to say you will counsel, not, you know what I'm saying?
You will counsel, but we will not enforce it.
Oh, well.
Yeah.
Okay.
It was like,
They did early on. They went around looking at sick pads and make sure they didn't have the option on the sick pads. I don't know if they did that with the chains.
Yeah, I mean, I worked at a chain for a while, and I saw a lot of people not get counseled, and nobody seemed to care about it. So,
do you want to name that chain?
Yeah.
Yes,
Absolutely.
I'd like to
go on
be.
record.
You can send the cease and desist order to my address.
Do you want to throw some very specific shade? All right. So we're going to imagine that you have a crystal ball there on your desk. We can't see.
Yeah.
So tell us, what do you see in the next year or two in independent pharmacy specifically, but community pharmacy? What do you see happening?
Yeah, totally. I think a big expansion of the provision of services. I think through medical billing, through credentialing, I see that's a big area of focus for us in Pennsylvania, is working directly with health plans for credentialing pharmacists for services, getting them paid for services as opposed to prescriptions. And I think nationally as well, as we've seen, restriction, or we've seen waivers that allow pharmacists to vaccinate, down to age 3 for any vaccine down to age 3. So we've seen some expansions in the scope of practice. I think there's going to be a lot of advocacy work, I think this is the time where we're going to see real movement in advocacy. If not now, then we've missed the boat.
Right.
Yeah. So it's all hands on deck for calling your legislator, talking to your senator, promoting the work that our pharmacists are doing. We meet with our luminaries. We have 18 luminaries in PPCN that are mostly pharmacy owners, and some are clinical pharmacists that work for a high-performing pharmacy that share innovation, that share insight into what they're really seeing on the ground, because that guide network development. So I could have a great plan for the network, but if it's not grounded in what's actually happening, it doesn't make any sense. So they help there are informants, really. And one of them today mentioned that he just recently had a meeting with a senator that lasted, twice the amount of time it was scheduled for. They were just really interested to hear from him what community pharmacists like him were doing. And he makes it really clear that he represents his pharmacy, but also he has this network of pharmacies behind him, 170 pharmacies in Pennsylvania behind him that are all doing similar things. And so when they're looking about implementing change, it's not just about this one little community. Right. It is about them, but it's relevant, beyond that. And he shared that, while physician practices were closed for 2 months, they're, in the early stages of the pandemic, they were triaging patients to care. They would take patients would come into the pharmacy, they take their blood pressure, they do an assessment in the pharmacy and work with the physician by phone to make changes in medications. And
they should be paid for that.
Yeah,
They're capable of doing it.
That's awesome.
They should be paid for it. Yeah,
Yes.
yeah. So they're capable of doing it, and the next step is getting them paid for it.
Yeah, it's interesting. You see this wave going through of anti-PBM sentiment in
the legislative environment,
state legislature. It seems like every week you open up something. I think Alabama was the last one that
Texas has a few of them on the board.
And a lot of those are passed. Yeah, I think Texas has ones passed the Senate and the House.
They have
and
a few
being
in the
reconciled.
Yeah.
Well, not the impressive thing for the Texas Senate was it passed almost unanimously, which never happens in the state.
Yeah.
It was 38-3 or something.
Right. So that's the next interesting thing of that wave going through those states is it's not partisan. It's been very, very weighted to pharmacy in this. And maybe the pandemic helped with that and the realization that we've got to have these guys. But I agree with 100% that the appetite there that finally, I've done some Washington stuff myself, and it's like they didn't even really get it.
Yeah.
Well, remember when we talked to that senator and we were talking about pharmacy, it was like we wanted to talk about something specific and he had no idea what was going on at all in pharmacy.
Yep. And so I think you're seeing more of your legislatures become better educated.
Yeah.
And as they get more educated, it's more likely to make a difference.
I know we're seeing a ton of legislative efforts around mainly PBM reform and restrictive networks, which need to happen. Agree. But services and creeping into other kind of, maybe some territory where doctors don't maybe want someone in there, and there's other advocacy groups that may not have interest in it. Do you see that being a little bit of a different appetite than, I know PBM reform seems to be really hot and it's rolling. What about preventative services from a legislative perspective?
Totally. We talk a lot about provider status. So APHA is really focused on provider status, although I think there's another term for it. This is where I should have done my research.
Is there some rebranding?
I think there might be a rebranded term, but and not because it's more than just provider status. It's about health plans recognizing pharmacists as providers. Really, that's what it means. Just like dentists and other healthcare providers. And then that opens up the billing. That opens up the or helps to solve for the problem of how do we pay pharmacists? Because that's our big, I can't even tell you. So through Flip the Pharmacy, so our practice transformation team in Pennsylvania has formed a Flip the Pharmacy payer advisory group. And we meet quarterly with this payer advisory group. There are colleagues in from different health plans and different payer entities across the state. And, they're with us. They're right there with us. Most of them are pharmacists. They're like, we get this, but what we can't figure out is the how to pay pharmacists for services when you're not on this list. Yeah. Because we go to credentialing and you're not on this list, so you don't fit into this bucket. So sorry, it doesn't work. And that's where I think a lot of the efforts from APHA and from the state pharmacy associations is going to be really, focused on. We're learning from Ohio. We're learning from Washington Pharmacy Association. We just met with them yesterday, actually, to learn about, how they did it. What's the trick? What do we need to know? What can we learn from them?
Well, it's interesting. Like Washington did this a while back, and the number of pharmacist providers in the state is still really, really low. Like under 1% of pharmacists are like billing for services. Now, the ones that are doing great stuff, right? Like your oral contraceptives, your, diabetes education, things like that. But it's still really, really low.
Is that because the barrier to entry is high?
Yes.
Is that what it is?
What is that barrier to entry?
Well, you have to get credentialed with every single
You have to have
payer.
enough density or
right.
market or addressable market probably to warrant the expense.
Right. Well, and even if you have one payer who figures out how to do it, you still have 50 where you have to go through every single one of those hoops and convince them, all right, look, I can really do this. Credential me. How do I credential? I don't know. And then, you have that other end where I think there are some groups that are focusing on it, but CMS really, as soon as they tie the pharmacist to be able to do work that counts toward MIPS and MACRA, it changes the game.
Yeah. How so?
Well, right now, if a pharmacist does work, say, you have a pharmacist in the community that drives all of your diabetic patients to the right therapy and the goals. The doctor doesn't get credit for that. And then their quality scores don't reflect their bonus. So they have to do the double work, and then the doctor gets paid for it. Which, if the doctor does the work, they should get paid, but it doesn't count both ways.
See,
it's hard to give credit to the actual individual or entity or the actual intervention. Like it's hard to pinpoint like what intervention actually caused that. But yeah, we're thinking about also if we want to be treated like a provider, then we have to act like a provider and get credentialed with every single health plan. And at the network level, so at this local CPSN network level, we're working with health plans to help manage that in kind of a roster type of format. If health plans are willing to participate with us, and that helps to take kind of like an ACO, right? Yeah. So it helps to take some of the burden off of the individual provider. They still have to give us the information, but it makes it a little bit more manageable from an onboarding standpoint. So I think that's kind of where we want to get to.
What are the not kind of shifting, but on CPSN, I know you're super involved, and I know vaccine efforts have been kind of top of mind for the most part, but you guys are fairly mature, or one of the more mature networks as far as like payer contracts in general, right?
That's correct. Yeah, so we for the past 4 years have worked closely with one health plan in particular, it's a Medicaid MCO, and our pharmacists were paid for providing comprehensive medication reviews for any patient with a chronic medication, pediatric to any age. So that was really cool to see pharmacists engaging with pediatric patients and helping them manage their asthma, for example, and then finding out that the parents smoke, and then working with the parents to help them to quit smoking. So it's like they were like treating the household as opposed to even just the individual patient, which was really cool to see. Now we currently have 2 payer programs launched with 2 different Medicaid MCOs in Pennsylvania, where pharmacists are being paid to provide care for asthma, COPD, diabetes, and the e-care plan is the source of truth in verifying eligibility for payment in that. So we're working with CPSN to facilitate the billing, so to speak. I don't like saying an e-care plan is a bill. That's why I want to get this X12 in your pipeline. But that is the source of truth. It has to meet certain criteria to enable that care plan to be eligible for payment for the pharmacy. So we've had good success. Again, the health plans are, they see the value in it, and we need to demonstrate it through the care plan. So we're really, really reliant on health plans going to do their own analysis. Like they're going to look at the medical costs. They're going to look at all of that. But we're reliant on the data that we can get out of the health or out of the care plan to tell the story about what's really going on. Like that family that I just mentioned, they identified the child had uncontrolled asthma. Well, then they also talked to the parents about, other risk factors in the home, and were able to really take care of them. That's what is exciting, and, in the role that community pharmacists can play in identifying some of those things.
So why do you think you guys have been successful in doing that kind of development with payers where other CPSN networks may not have been yet?
She's like, it's all me.
She's
we
all,
are persistent.
Stephanie McGrath,
it's
Farm D.
It's like right here.
We'll put some fingers pointing at you.
I heard this was a party, so I did invite a friend.
I love that.
This is a team. Like it is totally. I'm holding up for the viewers that maybe are just listening.
Yes.
Our Flip the Pharmacy Practice Transformation team was awarded Team of the Year for Cohort 1 for Flip the Pharmacy, which is awesome. And it's a team. And kudos to PioneerRx for being recognized as a technology solution partner of the year. You're part of our team. You're part of what has helped to make us successful. So thank you for your partnership in that. Josh literally coming out to Josh was some of our boots on the ground coming out to Pennsylvania before everything shut down, and helped to inspire and train our pharmacists. So it really is a team. It's our State Pharmacy Association, it's our Department of Health, it's our friends, our colleagues that support us on the health plan side, but it's taken years to get to this point, like a decade to get to this point of persistence.
Had a little bit, probably one too.
Well, and the really inspiring part about that is Pennsylvania is a big state, right? And you have 2 major cities on either end of the state with a lot of rural pieces in the middle. So when you see big states that are
3 different countries,
it feels like that in a lot of ways.
That's true.
But you see a lot of small states where oh yeah, it's easy because you can drive across the state in 3 hours. Well, Pennsylvania proved that you can drive across the state in 13 hours and still do this.
Yeah, totally. That's one thing that I think really enabled the success early on was that collaboration with all 7 schools of pharmacy. So their works are pretty widespread throughout the state, that cover a lot of geographic territory. And so faculty from all of the 7 schools of pharmacy contributed to this training program and were involved in the training, and we had connections and kind of their buy-in and support, and our State Pharmacy Association as well. But not to say, there are we have 170 pharmacy members across Pennsylvania, but there are hundreds more that are, I'm sure, high performing, that are hidden gems that we haven't engaged for whatever reason. And we need to really continue to make some changes. We've demonstrated that we can make changes with the group that we have, but for sure. And it's, reaching those pharmacy members is different we've had to use different strategies, depending on the geographic distribution of where they're located, for sure.
Yeah, there's probably how many independents are there in Pennsylvania? Probably 800.
I'm supposed to know
a lot.
This.
We've got
800.
We got 300.
I think we've got close to 300 in Pennsylvania.
Yeah, I think there's total. I think close to Close to that. It's up, not 1,000, but almost somewhere up there, creeping up there.
Well, I can't wait till trade shows start happening and groups start coming together and start talking about what happened in COVID and a lot of CPSN success in the last year and a half during this and kind of a breakthrough in how payers are thinking about pharmacy and
our magician in the back says there are 990 community
close.
pharmacies.
90.
I was right.
Is that community or independent? Not sure. Okay.
She's like,
the voice of God.
She's like, I'm deleting this.
She's
now.
like,
move
I
on.
don't know.
Move on.
But it started because you want to figure out, how do you replicate Pennsylvania, right? How do you replicate the good things that are going on in each one of these and quickly, really, because time is not our friend. And there's a lot of advantages right now going on in just in pharmacy.
Right, you've got a swell of, you just demonstrated a lot of capability, a ton of goodwill. Now, what do you do with it?
Right. When everyone's exhausted and
I know, right? You got to get back up.
Still trying to bill for all those vaccines. But you're totally right. I mean, it really illuminated how important community pharmacists are in providing healthcare. They caught so many people that slipped through the cracks of our system, especially during the pandemic. I mean, they continue to be accessible, continue to be resources for their communities for hand sanitizer early. We saw that was one of the first things, I think, the good stories that came out of this was compounding hand sanitizer and responding to that, working with local municipalities and local departments of health to meet whatever needs occurred. And then the vaccination efforts were just incredible and will continue to be. So I'm excited to see what else comes out of this. But you're right. I mean, there's been this huge swell across the country. It's not just in Pennsylvania. I mean, we have more opportunity now than we've ever had before. And I'm not alone in that. My colleagues, other CPSN network facilitators and other states are saying the same thing. And so we're trying to manage that and set our pharmacists up to be ready to execute, because the opportunity will be here for a short period of time. And if we don't execute, we're in trouble.
Super true. And you're right, though. You proved so much that you want to reach a vulnerable patient, that the best vehicle was proven under this pandemic is community pharmacy. Straight up was.
And it's another one of those things where, as pharmacists, especially if you've worked in a busy chain, you hate things like being able to walk in, you hate being in the drive-through all the time. But when you look at it, the things that made pharmacy successful in all of this was how accessible they were.
Yeah.
Right.
And the throughput they could push through.
And you saw pharmacists go from being like tired and angry because they just had a bad day to being like tired and really excited about their jobs because they just put out this amazing piece for their community. And we're finally getting like, hey, the pharmacist crushed this. Right. I've seen more pharmacists excited about working even, 16-hour days than I've ever seen in the last 5 years or plus.
Right. Well, you proved the agility of small businesses working in their community. Mm-hmm. The ones that are really successful were connected to their community. Their community called them,
Ran and Trip, you name it. We had them all. Mm-hmm.
Yeah, already had a relationship with public health, and public health gets a bunch of COVID doses, and hey, we've got to get rid of those. Who am I going to call? I'm going to call the guy down the street who I've been working with. And
well, like Eric's pharmacy with Marcos in Pennsylvania, they were like connected to their local public health, immunizing schools like crazy, like just wherever
the
they
big
were
chain
needed.
Can't do that because they can't really think individually and locally. They're not the person in the store is not empowered to think that way. So tell us, just to quickly before I don't know you very well, so just give us a little background of how you got into what you're doing. Just tell us a little bit about you.
Sure. I think it started, my parents are both healthcare providers. My mom's a dietitian, practitioner. My mom's a retired dietitian. My dad's a recently retired community pharmacist. So healthcare has always been, kind of indirectly, part of my life. When I was 16, I worked at a grocery store, and the grocery store manager said, "Hey, we need help in the pharmacy. Like, jump in the pharmacy and help out." So that was pretty eye-opening. I went to college and changed my major a few times, but ended up in pharmacy school at the University of Pittsburgh, and really enjoyed it. Really found some great mentors at the University of Pittsburgh that guided me to a residency program with the University of Pittsburgh and Rite Aid. And during that postgraduate training, was able to get a better understanding of how to provide care, how to get paid for care, how to work collaboratively with other healthcare providers. And I worked for Rite Aid for 10 years in a shared clinical and dispensing position where I got to take care of patients every day, and live and breathe that, ability to take care of people while I was filling their prescriptions and really make a difference. And then 3 years ago, was able to take this position with CPS and the CPCN network of Pennsylvania. And it's been great since there. I thought that I knew a lot of really great pharmacists in my past, life. But since taking this position, have been able to connect with some really innovative people across the state, across the country as well. It's been really cool to see what they're capable of, and to know that doesn't happen in isolation. This is something that's happening ubiquitously. It's been really amazing.
So what were the other degrees?
Yeah, I'm curious.
Oh, majors. I only have one degree.
Sorry. What were the other? You said you went a couple of different directions before you decided on pharmacy. What were the other directions you went?
So I was a psych major, and then intro to psych pretty much did me in there. And then I was a chemistry major, and loved chemistry, but I couldn't spend my life working on a bench, in a lab, just not the type of research that I want to do. Now I'm involved with research, that's different. It's
not on the
qualitative research, other type of research that's fun and exciting. But
one of the things we talked to a lot of what I consider pharmacy leaders on this show. And it's funny how often we hear a story that pharmacy wasn't their first choice.
That's true. There's a lot.
Right? There's a lot of that.
And
a lot of coming from pharmacy families where they did this and they did this and they did this, or they stumbled across this, and where it really wasn't hey, I want to go into pharmacy was their kind of first thing. And I don't know if that says something.
Yeah, it actually worked against me for a number of years, seeing, I want to do something different, because my dad was a pharmacist. But I did get the opportunity to work with him for a few years when I was in pharmacy school. And it was really cool to see the problem solving that he did. Patients would come in and, with medication related problems and non-medication related problems. And I think that was my first experience seeing what great problem solvers community pharmacists are, because they have to be, because they were, people come up to you because you are so accessible and expect you to solve their problem, and you figure it out. And they do a great job of it. So that was that was kind of my first experience seeing it, and then, was able to do that myself for a number of years, which is incredibly rewarding.
Hitting the end of our time here. We wanted to tell you again, congratulations on your team, and thank you for all you're doing for community pharmacy and all that that you're probably gonna do the next couple of years, and let you know we're here. So don't feel like you had to wait to get us on recording to say, hey, can you work on this for us? So, give us your ideas. I know,
it's like I got you on record.
I know I got one over here beside me who's itching to get back out to Pennsylvania. And so hopefully he'll be out there soon, and just continue to work with you guys to spread what you do and make what you do happen more often.
Awesome. Well, thank you. Thank you for your partnership. Thanks for your support. And Josh, you're welcome anytime to Pennsylvania. We got a lot of pharmacies that would love to.
I'm fully vaxxed and I'm ready to go.
Love to give you their feedback too.
I know that.
I know that. All right. It was nice meeting you.
All right. Thank you again for the opportunity.
Thanks,
Take
Stephanie.
care.
All right. Bye-bye.
All right. Bye.
Thank you for watching the Catalyst Podcast. If you enjoyed this episode, please consider liking, subscribing, and/or following us. Give us a 5-star rating on Apple Podcasts to help us reach more amazing pharmacy people like you. Follow PioneerRx on your preferred social media platform for the latest up-to-date pharmacy news and content.